Well, good afternoon, everybody, or morning, depending on where you are logged in at. This is going to be a quick, high-level, get to the key changes. I have planned to go through every single element and highlight things that stay the same, but spend most of the time focusing on things that have changed that we need to be aware of. So as you know, most of you know who I am. I'm President and CEO of Quality First Healthcare Consulting and do a lot of work with federally qualified health centers as well as PCMH. And as you can see from the screen, I am a certified content expert and also serve with NCQA as a contracted reviewer for their products, and am on faculty with them to do leadership series and workshops on the Patient-Centered Medical Home standards. So those will be coming out. I think the first 2014 set of workshops, which is the 2-day workshop, is going to be held in Tampa in May of this year, and then the next one I believe is in Providence, Rhode Island, which is sometime in July. And I think those are the only two right now that are scheduled if you want to attend that kind of a workshop. So a couple of things, important dates I wanted to bring to light in terms of the 2011 standards, and the fact that you can continue to use and apply and work towards the PCMH standards under the 2011 year. However, there's some important dates that I posted here for you to think about. The first one is that if you plan to use or go or seek a renewal or seek NCQA recognition under the 11 standards, you must have purchased the ISS tool by June 30th, 2014. So if you haven't done that yet, I would encourage you to go to the NCQA website and download and purchase that, which is about $80. The last time you can actually submit 2011 standards under the corporate survey tool is December 31st of this year. This is a date that's recently been posted. To keep in mind, if you're planning to do a multi-site under 2011, you must submit the corporate tool by December 31st. The last day that you can submit any applications, corporate or initial or renewal under the 2011 standards is March 31st, 2015. So you have about 12 months in which you can continue to focus on the 11 standards. As the first one we're going to go through is the must-pass PCMH 1A. NCQA has not made any changes in 2014 in terms of the number of must-pass. There's still one per standard, so there's 6. But there has been some changes, at least one change in a must-pass element, and we'll get to that down the road. But it is the care team element that talked about in the 11 standards. It was 1G. I believe now it's 2A. That is now a must-pass, with the consideration that having a good structured care team with processes and protocols in place, standardization, and good communication is a critical component to a successful and sustained PCMH model. So that now has become a must-pass. Under 1A, and as we go through these, I'll quickly point out how the slides are set up so you can focus in on certain things. If I'm listing all the factors, and the ones that have some change to them are going to be bolded. In the red, you'll see that the change is in red, or if it actually aligns with a 2011 standard, then I have that noted. So you'll see that under Factor 2, providing routine and urgent care appointments outside regular business hours. That actually aligns with PCMH 1B, Factor 1 of the 2011 standards. So if you're doing some kind of crosswalk and you want to use this slide presentation and print it out or whatever, you can go back and say, okay, this one hasn't changed from previous. The ones that are new, they have new right next to them. So right off the bat, you can tell that the first one is a must-pass element, and you have to meet at least 2 of the factors, and there's 6 factors, and one of them has to be factor number 1, which is providing same-day appointments. There is a slight change in this particular factor in the fact that they want to see that you evaluate. You actually have to address routine and urgent. It was in the standards in the 2011, but it wasn't as detailed as it is now. That requires you to have certain criteria around routine and urgent, that you make same-day appointments scheduled for routine and urgent, and that you actually evaluate. So when that report is due, then it's going to list routine and urgent, and did you evaluate that you had availability for both. Number 3 is a new factor, and this is alternative types of clinical encounters. The intent of this is to see if practices are providing different types of encounters. This is not telephone access. This is not e-secure messaging. This is things like group visits and other types of home visits, things that are totally different in terms of a clinical encounter. The next new one is factor 4. That's availability of appointments. And availability of appointments, what they're looking for here is, do you have some standards in place? And they want you to set some standards for how to make appointments. For example, preventive care. A preventive care appointment might be within 6 weeks. Urgent care appointment might be the same day. Sick care might be within 2 days. Some type of standardization would be in a process, and they also want, when you generate a report to them, they want you to monitor wait times. Monitoring no-show rates is, again, something that's new. This is usually not new to federally qualified health centers in terms of monitoring no-shows. However, they want to see that you can monitor that. And they're going to be looking for a report on your no-show rates. And that could include no-shows by cancellation, no-show by missed appointments, or other factors. But they want it as detailed and specific as it can be. The new one, which is probably going to be the more difficult to achieve in the 2014, is factor 6, acting on identified opportunities to improve access. This is actually taking all the reports that you're generating and monitoring on a routine basis from factors 1 through 5 and determining with goals and benchmarks how you're doing. And if you're not meeting your estimated benchmarks or thresholds, then demonstrating through PDSA or some kind of CQI process that you are identifying opportunities. They require that you identify at least one opportunity out of those reports from factor 1 through 5, and that you initiate actions to improve.
Muted. Unmuted.
Now we're going to move on to PCMH-1B. I'm getting a lot of feedback. And so factor 1B, what they've done is they've kind of combined factor 1A and 1B together. And this one has to do with 24/7 access to clinical advice. I'm not going to spend a lot of time on this one because, as you can see, they pretty much are the same as in the 11 standards. They've just kind of combined A and B together. So I've got the alignment of the 2011 to the 2014 there for you. 1C is electronic access. This is the same element as was in the 2011 standards. You'll see that there's some new ones. And actually, NCQA calls number 1, factor number 1 is new, but in actuality, it seems to be aligned pretty closely with factor number 2 of PCMH-13 in 2011. However, the percentage has increased from 10% to 50%. So each one of these that are core or menu meaningful use in the 2014 standards are the stage 2. So we've moved from stage 1 to stage 2. You'll notice, and as a kind of what I call tips in the margin, if you've got your standard book out, is that the percentages have changed in quite a few of these from stage 1 to stage 2, and that's something to be aware of. What I've done is gone in and marked my book, highlighted it when there's been a percentage change. I've tried to pick that up for you in the slide presentation, but I may have missed a couple. Number 2 is new. This is a stage 2 core, and they want to see that at least 5% of patients view, have ability to download and possibly transmit their health information to a third party. So what that means is at least 5% of your patient population has access and capability to do this. Factor 4, again, is it's a core stage 2 meaningful use. I'm not going to go into that. That can be, you can look at your meaningful use requirements to see the denominator and numerator for that. And these are all going to be reports. 5 and 6 are aligned with 2011.
There are a number of questions that you may have as you go along. If you will, please, there's a questions section to the GoToWebinar dashboard, and if you'll type in your question, At the end of the webinar, we will go through all these questions and answer them. And at the same time, there may be other questions that don't make it to the question board. So if you will, please, this is how we will address your questions.
Oh, thank you. Let's move on to PCMH-2A. 2A pretty much aligns with the 2011 standards with the exception of Factor 3. And Factor 3 is having a process to orient new patients to the practice. The intent of this factor is that you have some type of a process in place and on how you provide information and orient new patients to the practice. Information that would be included in this orientation would be information about the medical home model or the concept, medical home responsibilities from your practice or health center, and also medical home responsibilities related to the patient. The documentation requirements would be a documented process, and it's been very clearly specified in the new standards at the beginning of it's either the documentation or explanation section that documented processes must have a date on them in which to determine that they have been implemented at least 3 months prior to submission of your survey tool. So this requires materials and a process. PCMH-2B is medical home responsibilities. This correlates almost directly with 2011 PCMH-1E, which is also titled medical home responsibilities. But there is some new factors, and there are actually 4 of them, and there are 8 factors in 2B. So this slide goes through factors 1 through 5. The first 4 are very consistent with previous standards. Number 5, scope of services available within the practice. This is making available to members in some type of format, whether it's a brochure or other types of printed materials, website, the scope of services that you provide within your health center, and information on how patients can actually address their behavioral health needs, whether that's internal or external. So how those referrals are made. Factor number 6 under medical home responsibilities is also new. This is the practice provides equal access to all their patients regardless of source of payment. This is an evaluation of how you assess the needs of the patients and make provisions for that. Examples in the standards include things like making available that you see patients on regardless of ability to pay, or that you see patients from multiple age ranges and multiple insurance payers, such as Medicaid, Medicare, commercial. Those things are all acceptable. Factor number 7, the practice gives uninsured patients information about obtaining coverage. This is also new. And this is how do you help patients and what kind of information do you give them, particularly if they're uninsured, on either how to enroll in the healthcare exchange or to enroll into Medicaid or one of the other types of programs that they might be eligible for. Number 8 is instructions on transferring patient records to the practice, including a point of contact. This has to do with assisting patients in transitioning from a previous provider to your practice. And it's more than just giving them information, it's actual assisting them and obtaining the point of contact at the practice. And that means it's the point of contact from the transferring practice over to your practice. PCMH-2C is culturally and linguistically appropriate services. And this one, factors 1 through 4, if you're familiar with the 11 standards, you can look right at this and say, wow, nothing's changed. And that is absolutely correct. This one is staying the same. PCMH-2D, this is a must-pass. And this has also got a critical factor involved with it. In order to pass this one, you must meet at least 5. There are 10 factors. We've got 5 on each slide, so the first 5 are viewed for you. But there are 10 factors, and you must meet at least 5 of those factors, including factor number 3, in order to pass. And to pass, a must pass is still at 50% of the points. And that has not changed since the 2011 standards. So let's go to factor number 2, which is actually the first new one. And this is identifying practice organizational structure and staff leading and sustaining team-based care. The emphasis on this is the fact that team-based care needs to have structure, protocol, standardization, consistency within it that's very well formalized, very well understood and communicated across the health center so that everyone knows their very distinct roles and responsibilities, and that team-based care can be sustained over time. That it's not something that is put together for purposes of getting PCMH recognition, but it's actually moving towards a full transformation and redesign of your healthcare delivery system. It can be demonstrated through an organizational chart. It may be used, and it's used to delineate responsibilities of each individual team-based member. Factors 3, 4, and 5 are all consistent with the former PCMH-1G. Factors 6 and 7 are related to the training program that are given to care team members at orientation or possibly refreshers throughout the year. Number 8 is holding regular team meetings addressing practice functioning. And this one, and I apologize, I didn't go back and talk to you about factor number 3. Factor number 3 on the previous slide. I'm not sure I know how to get back to the previous slide, but factor number 3 and number 8, what has happened there is it used to be the whole huddle, factor number 2 and 1G, where we talked about the structured communication process or the huddling, and there seemed to be some confusion about what that really needed to be, and oftentimes what was presented was staff meetings where they actually huddled, but they talked more about staffing and practice function and omitted the patient-related discussion. So now they've separated it out. Factor number 3 in 2D actually talks about the individual patient-related daily huddle, where that's what you're talking about. And then they added factor number 8, which is holding regular team meetings addressing practice functioning. This is more related to your staff meetings, or it could be other types of communication. It could be daily, but it doesn't have to be, where you are addressing those things that are important to your care team, but they're not necessarily patient related. So that's factor number 8. Now we move to PCMH-3E. This is patient information. You'll see that this is very similar to the old PCMH-2A, but they have added 2 new things. So instead of going 1 through 12, we now have 1 through 14. In factor number 8 is the first new one, and this is occupation. They want to know if you have some type of structured data field where you can actually collect and report occupation. And that is, and particularly the reason for that is it's to help identify health risk behaviors that might be associated with the fact that may be related to occupation. An example of that might be, someone that works in the mine. It could be someone that's uninsured, whose health risk behavior is, it could be related to poor access, or a lot of different issues. So they're doing that to try to get that information available so that you have an opportunity to create population-based interventions based off of occupation or job status if it's applicable. The other new one in PCMH-3A is name and contact information of other healthcare providers, professionals involved in patient care. This one does not require a structured data field, and it doesn't require a report as 1 through 13 do. The intent of this is that you have the capability somewhere. It could be a text box. It could be in a structured data field if you have it, in which you can collect the name and contact of providers that the patient's seeing outside of your practice. For example, it could be a behavioral health provider. It could be a dental provider. If you don't do OB in your practice, it could be an OB provider, and that you have the capability of doing contact information. It requires a documented process, a screenshot of the data source, so that would be where you would place that information, and then 3 examples of actually information that's been placed in your system. (3B) is clinical data, and this is very similar to PCMH-2B. But know that there are some percentage changes and some age criteria changes between the stage 1 core menu meaningful use and stage 2. If I don't have anything written in red here, then that means that it has stayed consistent between stage 1 and stage 2, and you can evidence that by looking at factors 1 and factor 2. And that means that these particular core meaningful use requirements have stayed exactly the same. Factor number 3, the blood pressure. In 2011 it was 2 years and older. They've now made that consistent with meaningful use and changed that to 3 years and older. Height, length, and weight, they all have had an increase in percentage up to 80%. Factor number 6 is system calculates. That remains the same. That is still looking at the functionality of your system and providing a screenshot on how the system calculates and displays BMI. Factor number 7, this one is primarily the same with one exception. The difference is that it used to have two different years. For example, the first one was in months, system plot display growth charts, and then BMI was in the 0 to 20 years. So they've now combined that together and it's just 0 to 20 years in terms of displaying with a screenshot. Number 8 changed in terms of percentage. Number 9 stayed the same. Number 10, this is new, and this is stage 2. And this is actually a menu, meaningful use, in which looking at structured data fields for collecting patients that have family history recorded. It's interesting to note here that if that is unknown, if you ask the patient doesn't know, that's considered a positive hit, and that can be counted. And number 11 is also new. This is another menu. Stage 2 requirement. I'm not going to get into that again because this is a report that's generated basically through your system. See how we're doing on time. We're doing pretty good. PCMH-CCE, Comprehensive Health Assessment. This one's a little bit different. You can see that the factors 1 through 9 are consistent with the 2011 standards in PCMH-2C. But there are some new things that go with it, and that would be, one is, number 10 is actually new, and that's an assessment of health literacy, and that is the ability to assess patient, family, and caregivers' ability to understand the concepts and care requirements, which that could get into self-care and self-management and whole person type care, associated with managing their own health. And is that documented in the system? Before, in the 2011 standards, you could demonstrate comprehensive health assessment by providing examples of completed patient assessments or providing a documented process on how you would collect this information initially and in routine periods of time when the patient comes in. This is a little bit different this time. This one you can actually provide this by a report. If you can pull from your system the total population and present it in a report, for example, let's look at factor number 3, communication needs. If you have a structured data field for that and communication needs, and you can pull a report of all your population and generate that, you know, what percentage of your patient actually have that assessed because that information is in there, you can do it that way. Also, this one seems to include something about the record review workbook in the explanation section. I've read that and I'm not real clear about the focus of using a record review workbook for this particular element, and have actually asked and sent a policy clarification to NCQA about this particular language that was in there. So if you see that, you might want to just circle it or put a question mark by it, because it talks about calling patients, doing telephone scripts, patient reminders for when they don't have services needed, which sounds to me as a lot like the old PCMH-2D. So it could be an error in this first publication. I did want you to make note of that if you see that might confuse you. PCMH-3D, this is a must pass. And in order to pass this, and there are 5 factors, you must get at least 2 factors. There are no critical factors in this, so 2 out of the 5 factors must be met. This one's very similar to PCMH-2D, factors 1 through 4, with the exception that they actually culled out and added immunizations. Previously in the 11 standards, when they talked about 3 preventive care services, it wasn't quite clear initially what those preventive care services could be, and they used to accept that you could do immunizations as preventive care services. Toward the end of the 11, they did a clarification that said, no, you can only do 1 immunization and the other 2 have to be different. So here I think they're trying to be a little more clear, and they separated it out. So factor 1 is 2 different preventive, and then they added 2 different immunizations. So you're actually doing a little bit more for this one than you did in 2011. Factor 3, 4, and 5 are the same as 2011. 3E, this is implement evidence-based decision support points. And this has a critical factor, which is factor 1. And it does have some new factors included within it. If you remember previously, this was PCMH-3A, and this had to do with identifying important conditions, recognizing evidence-based guidelines, and then providing screenshots or flows on how you implemented point-of-care reminders using your evidence base. It's very similar to that in terms of what's required, but you can see that they've added a chronic medical condition, they've added an acute condition, they've added well child or adult care, and they've added overuse and appropriateness issues to it. So it's a little bit more involved than it was before. For A, this is identifying patients for care management. There's quite a few that are new. And documentation reviews criteria and processes for identifying. Previously, this would have been mostly aligned with PCMH-3B, which was having a process for identifying high-risk complex patients and then providing a report that showed how many of those patients were high-risk and complex. This is now, and to me, this is really expanded from the 2011, and this has to do with case finding. They want to see, do you have the capability and have criteria in place for identifying patients in each of these different areas? And they want to see your process for how you identify it, and then that's your criteria, and then they want to see the process for identifying. So they're looking at things like behavioral health conditions. What would you be looking for, and what would your criteria be to case find patients that might have behavioral health conditions that could set them up for some type of benefit from care management? Again, high cost, high utilization. The example of that might be ER use, hospital use. It could be no-shows, poorly controlled or complex conditions. These could be things that, like a poorly controlled diabetic, looking at their A1C levels. Number 4 is social determinants of health. This one is extremely important in the fact that it looks at assessing, creating some kind of criteria for assessing things outside of just the clinical parameters of a patient. So what would be things in their environment, what would be things in their lifestyle, economics that could impact and case find and identify and refer for care management services by your care team. Number 5 is referrals by outside organizations. This is, you have the ability for outside or external organizations to make referrals as well as patients, and if you get that information, is any of that could be identified as high risk, or if they're getting a lot of external referrals, something that might need to go to care management for better transitions. And then the practice monitors the percentage of the total population identified through its process and criteria. And what that means is you take factors 1 through 5 and the patients that are identified and come up with your patients that are probably most suitable for some type of care management. For B, this is another must-pass. This is the beginning of your record review workbook. Things have changed a little bit in the types of things that we recorded and attested to through the workbook. PCMH 4B and 4C are going to be the two elements that the record review workbook coincides with. But as you know, NCQA always gives you another option, and that option would be to do a full population query of your system. Usually, if you have a registry, then you can do that and report that way versus using the record review workbook. If you use the record review workbook, then patients will be selected from element A for that, and that would be the patients that are considered high risk and complex that we just talked about. So there's a couple of new things in this one. Incorporates patient preference and functional lifestyle goals, identifies treatment goals, and includes a self-management plan. These are very similar to what was initially in 4A, PCMH 4A, but they were lumped together into one or two factors, and they have now separated it out, so each one has its own identity and its own purpose and its own ability for you to meet or not meet. For 4B, in order to pass, let's see, I don't think I had that down there. Let me pull it up. In order to pass 4B, you have to, hold on just a second, let me look. You have to meet 3 out of the 5 at least 75% in either a report or using your record review workbook. So 3 out of the 5 will give you the 50%. 4C is medication management. This one is very much aligned with PCMH 3D in all the factors. You'll note that I did highlight caregivers in red, and that is the difference between the 11 and 14. Used to just say patient and families, and now they're including caregivers as well in terms of providing information about new prescription and assessing understanding. PCMH 4D is the e-prescribing, and this is very similar to PCMH 3E. You'll note that because it's now stage 2 core meaningful use, the percentages have increased since that. So I've highlighted the difference in the percentages so that you can see the differences in each of those. Factor 3 and Factor 4 are aligned with PCMH 3E. You'll note that the formulary status has been discontinued as its own factor, but it's now somewhat rolled into Factor 1 at the top that talks about more than 50% of eligible prescriptions written by the practice and are compared to drug formularies and electronically sent. So they've actually combined the two together. It's now become a stage 2 core meaningful use requirement. These Factor 1 and 2 are going to require a report, and Factor 3 and 4 require a screenshot demonstrating the capability. I will take a minute here to note that I'm not going into all of the documentation requirements that are in the new standards, but I would encourage you to look at them very closely. They are, I would say, primarily consistent with the 11, but there are some changes, and they generally have to do with whether or not a documented process is still required, and the examples have changed. Sometimes it's one example, sometimes they've quantified it to be 3 examples. So they're giving more detail about the number and type of materials and documents that are required. Some of the report time frames have changed as well. Instead of 5 days, they're now asking for 30 calendar days. Again, tip in the margin might be to pull your book out and for reports, highlight things in a certain color. For processes, highlight that in another color so that you can quickly see the differences. Moving on to 4E. 4E is support self-care and shared decision-making. And the practice has and demonstrates use of materials to support patients and families. A lot of this used to be the 11 4A standards, which were part of the record review workbook and actually had some percentages associated with them. You'll see here that number 1 is actually now a meaningful use requirement, and it was in the 11 as well, but it could be demonstrated through record review workbook instead of a report. But the percentage hasn't changed. Factor number 2 and factor number 3 were part of PCMH 4A, but they did have percentages associated with them, and now they do not. Factor number 4 is new. This is adopts shared decision-making aids. And what this means is when you have a patient that is complex and there's the necessity to have some complex decisions about treatment plans or options that patients may have, what kind of process and what kind of aids do you have in place that can provide some detailed information to patients and families or caregivers to help them make a decision with the care team without actually leading them to choose a certain option. So it's giving them value-based options, it's giving them the information they need to make their own decision, of course, with the help of the care team. And that's what the decision aids is about. Let's see, the next one that's new is factor number 7, assesses usefulness of identified community resources. What is looking for here are materials used or surveys. You may want to use a survey, or you may have different materials that actually tell how the practice collects information on the usefulness of the referrals to community resources. So a survey could be, did we help you make a referral to a community resource? How satisfied were you with the resources that you received? That would help meet this factor number 7. Factor number 2 through 5 of note, these would be examples of resources. That is what's required to demonstrate that you meet factors 2 through 5 of this particular element. Now we're into PCMH 5A. That has 2 critical factors. This is test tracking and follow-up. This one now has 10 factors to it, and out of those 10, 3 of those are new. You can see on this particular slide that none of them are new. They're exactly the same 1 through 5 as they were with PCMH in 2011 5A. So these require a documented process, and they require examples of how you've implemented the process. Now moving on to factors 6 through 10, factor number 7 is new, factor number 8 is new. Previously, you basically had to show that you had and demonstrated capability of sending and receiving electronically laboratory orders and results, and which correlates with the new factor number 7 that's now a meaningful use report. Factor number 8 correlated in 2011 to the capability of your system to send and receive radiology results. That is now a stage 2 meaningful use report. Number 9 stayed the same with the exception that the percentage went up to 55%, and this is your structured data fields for lab results. And factor number 10 is new. This is a menu meaningful use, and if you are familiar with the 11 standards, you'll note that this particular one required just an example of a scanned image of an image into your EHR. Now it is a report. PCMH 5B is a must-pass. This is the same in 11. This is your referral tracking and follow-up, which was a must-pass then. It now has 10 factors associated with it, and in order to meet to get your must-pass and get it your 50%, you must meet at least 4 of the factors, including factor 8, which we'll talk about on the next slide. But factor 8 is your critical factor. So before it was 3 factors, I think, out of 6 or 7, and with no critical factor. So this one has gotten more stringent in 2014. Factor number 1 is new. It considers available performance information on consultants and specialists when making referral recommendations. What is in place at your health center or your practice to inquire of previous information of performance of consultants and specialists? This could come from health health reports, health grades, or some other kind of profile reports. It could come from CMS. It can come from health plan directories. But, you know, we want to see what source do you have in place, and do you consider and review this before making a referral to a consultant or specialist. Number 2 is also new. Maintains formal and informal agreements with a subset of specialists based on established criteria. This criteria is basically an articulation of the arrangements for exchange of information. And you'll see that factor 2 is for a subset of specialists, and factor 3 drills it down a little bit more about maintaining agreements with behavioral health providers. In behavioral health providers, that can be internal or external, but basically that agreement again is on how do we work together, how do we exchange our information. If it's internally, it could be, you know, we have access to the same EHR, and we also have given access to notes, those kind of things. Factor number 4, integrates behavioral health providers within the practice site. And this has to do with integration, whether it's full integration, where you bring behavioral health providers in on maybe a part-time basis to see patients or do counseling of patients, or whether it's full integration where you actually have behavioral health providers employed or on-site in other arrangements every day that your center is open. Factor number 5 is consistent with factor number 1 from PCMH 2011, which is the type of the timing and of clinical information. Now let's move on to the last set. This is 5B. These are 6 through 10. Number 8 is the critical factor, as mentioned earlier, and this should be familiar to you in tracking referrals until consultant or specialist report is available. So it combines factor 2 and factor 3 from the 11 standards together. This is a critical factor because this means that there's a closed loop process in your referring, that you're not just referring out, and but you have a capability in a tracking system that actually flag and alert you when something might be overdue. You haven't gotten a specialist report, or maybe the patient didn't go, and that you do something to follow up on those overdue reports. Most factors in 5B require either a report and at least one example. PCMH 5C, this is coordinate care transitions. You'll see that they are pretty much aligned with the 11 standards. Factor number 1 added 2 words to it, and it's proactively identifies patients with unplanned hospital admissions and emergency department visits. This is that list or report that is generated from the hospital to the practice when your patients have been admitted or have had an emergency room visit, or it's an internal process that the practice health center reaches out to someone at the hospital to secure that information. The new one is number 6. This replaces the old written transition of care plan for practices that saw pediatrics, and they need to transition them to an adult provider outside of their practice. Now this has changed to obtains proper consent for release of information and has a process for secure exchange of information and for coordination of care with community partners. That's a mouthful. This one, again, I've reached out with a policy support clarification because in the explanation and documentation section of the 2014 standards, it looks to be still related to a written transition care plan, and it doesn't seem to actually match this particular factor. So if you see that, you might just want to put a question mark about that and see if we get some kind of a clarification statement from NCQA with some explanation. Now we go to 6A. You'll see right underneath the PCMH 6A language that there's some language that I've bolded and highlighted, and I would really want those that are on the call that are currently recognized under the 11 standards that will most likely be required to renew under the 16 standards or 14 standards, is that they now have several elements, and they're all in 6A, that have this statement, and it says renewal surveys. NCQA reviews reports showing the practice has measured at least annually for 2 years. So these are going to be important for you to make note of now and start putting in place your implementation and how you're going to measure and report that at least annually for 2 years. So if you go through, let's say that you're good in your 2011 recognition until 2015. When you go through in 2015, you most likely are going to be renewing under the 2014 standards. And for this particular element, they're going to require at least 2 years look-back period. So it would be, if you applied December 31st, 2015, they're going to want to see that you have reported these out for at least 2015 and the year 2014 as well. The reason they're doing this is to make sure and try to get some indication and assure that the practices are sustaining quality programs. For health centers, this is probably not going to be as difficult as maybe private practices because many use their UDS information for this as much as they can, and as you all know, that's reported annually, so you should have that. But just for note, this is something brand new, and this is the first attempt at looking at look-back periods to assure that sustainability of your recognition PCMH model is in place. So there's a new one for this, and that is factor number 1. Factor number 1 is at least 2 immunization measures is what they're looking at, and these are reports of results. Factor number 2, this aligns with 6A1, except it used to have 3 preventive care measures. Now it has 2 measures instead of 3, and I think the reason for that is because they added factor 1 to it. Factor number 3 and factor number 4 are consistent with PCMH-6A2 and the 11 standards. All of these require reports. 6B, this is new, and 6B again is requiring for renewal surveys to demonstrate that they measure this at least annually for 2 years. And this is measure resource use and care coordination. Remember in the 11 standards in 6A, they had a factor that was at least required you to report, or you had an option to report 2 utilization or cost of care measures. They've now separated that out, and it has an element all its own, and factor 2 is the one that coincides with that, but they've added factor number 1, which is you're measured at least 2 measures related to care coordination. Examples of care coordination that you might want to consider would be, let's say, transitions, care transitions, patients transitioning from hospital to your practice, patients transitioning from a skilled nursing facility to home that you're aware of, med reconciliation, patients being discharged from hospital back to your practice. These are all good examples of care coordination measures. And NCQA has done a very good job at giving you a long list of examples in care coordination. And again, these are performance results reporting. PCMH-CCE, again, you'll see the renewal survey look back period. This is measuring patient and family experience, and this aligns completely with the 6B factor 1 through 4 element in the 11 standards. So there's been no changes here. 6D is a must pass, and 6D is the old 6C, and usually most practices are using the NCQA provided QI and improvement worksheet. And this one, in 2011 you had 5 measures that you would put in your worksheet. Because of the way this is set up in this element now, it's actually going to be 6 measures that you'll be presenting in the worksheet. You have 3 clinical quality measures. You have 1 measure which is either utilization or care coordination, and that is the 2 new factors. That is factor 3 and factor 4. You have 1 patient experience, and that's factor 5 and 6. And then 7 is your disparity of care, vulnerable population measure. So you can, NCQA basically what they did is they separated out the goals from the acts to improve. In the 11 standards, those were together. You establish goals, or you set goals and benchmarks and act to improve upon them. With this one, you can actually, each one is separated, so you can get a yes for one, and possibly you may have set goals, but you didn't actually act on them. So at least you would get some credit for setting goals, which would be, let's say under clinical quality measures would be number 1, but you didn't act on it, so number 2, you would score yourself no. So it gives you a little bit more indication and points that you might be able to accrue. PCMH-CCE, demonstrate continuous quality improvement. This is aligned with PCMH-CCE factors 1 through 4. Again, this is usually demonstrated through the worksheet that NCQA provides for you. And the only note difference here in which I noted is in 2014 includes improved performance in 4 measures instead of 2. In 2011, you had 1 factor. If you improved performance, you got credit for, I think, factor 3. And if you did improve performance in a second measure, you got credit for factor 4. So they've now increased it from 2 to 4. 6F is report performance. This aligns specifically with PCMH-CCE, factors 1, 2, and 3. And you'll see it actually has an additional factor to it, but what they've done is they've kind of separated things out, made it much more clear. But the intent and the actual documentation requirements are the same. 6G, this one is interesting. And 6G, in 2011, remember it was use of certified EHR. It was a non-scored element, and it also, you basically put your CHPL number, your certification number, and then you attested to whether or not you had a security risk analysis done. What this one has done, and it's still not scored, you'll note that it's still not scored, but it has grown significantly. It now has 10 factors associated with it, and it looks like it has merged 6F, which was reporting data externally. Remember, reporting your UDS, reporting to CMS, syndrome surveillance data, immunization registry data, and that was a scored element. But they've combined the two together, it looks like, and it's not scored, and basically every one of these is by attestation only. So factor number 1 and 2 came from 6G, and then factor 3, 4, and 5 came from 6F, in which you had to generate reports. Factor 6 and 7 came from 6F. Factor 8 is new, 9 is new, 10 is a stage 2 core meaningful use. The key point here is that there is no documentation required for this. It's simply an attestation, with some of them require some narration in the support text in the ISS tool. Some of them is just by attestation only, and that would be by selecting yes or no in the ISS scoring box. So I think that's it. That was a lot. If anybody has any questions, do we have any questions in the queue?
Yes, the way I'd like to handle this is I've learned that if you ask a question and then get an answer, many times the answer will induce more questions. So the way I'd like to handle this is, if I may, I'd like to unmute the person that's asking the question and allowing them to ask, and respond if there are any additional questions that the answer causes, as well as if anybody else would like to interact with the question. If you'll raise your hand digitally on your dashboard, I'll unmute you as well, allowing you to be able to interact. Tim, I have unmuted you. If you will, please ask. You've got a number of questions.
So this is Tim. I had submitted a couple questions. First one was regarding the patient portal and the requirement of hitting 50% of the patients. We struggle with that. Most, not very many of our patients actually own computers, and let alone then the next step of it where they're actually using the portal. So I'm wondering how we can get around that or what we can do to meet that, considering the population we work with.
Oh, hi, Tim.
Hello.
In the 2014 standards, there's only one way you can take an NA for some of this. So, and that is if you're in an area where you don't have broadband access or you don't have that capability from an internet perspective. It doesn't relate to whether or not you can get your patients to use the portal. I agree it's sometimes difficult for patients to use the portal, and it takes some innovative and creative solutions, such as, you know, walking patients through it, possibly in the lobby when patients come in, and having someone a resource out there periodically to say, look, we have this portal now, we'd like to get you enrolled, here's what the benefits of it are. Any type of information, continued positive reinforcement for what's out there. But I agree with you. In the population the health centers serve, this sometimes not, it's just not doable for them. And I think that's why one of the requirements now that it's moved to a stage 2 meaningful use requirement under C is that it's only 5% of the population. So they're keeping it relatively low, and that could be, I'm not for sure, but it could be because they understand that it's going to take a while to get this new type of media and patient engagement in this new type of media underway. This is a very good question. If you find out a best practice, will you please share it with everybody?
Yes. Yes, indeed. I mean, I'd be thrilled if I could get 5% of our people signed up, let alone to get 5% of them to use it. So that's an area we're going to have to work on.
Sure.
But I had another question also. Since we worked on our first submission, we have gone to an open access model here at Family Health Center, and anywhere on any day, 60 to 70% of the appointments are open access or same day. And it's very difficult with huddles. We used to do huddles every morning. We'd put a box in for them to click. Because so many of your patients are just coming in that day, we have standard work for our MAs where they're going to gather a MAPS report, or they're going to gather any ER or hospital admission data prior to the provider seeing them, but they're not doing frank huddles any longer simply because we've changed our model of how we see patients. How do we get around that, or how do we comply with that?
Well, NCQA doesn't require a huddle, so to speak. That language was used in the 11 standards, and it was bolded, and the perception was that this is what we have to do, but there was another piece of that talked about a structured communication process, and that can be done in various ways, and that's up to the health center as to how they do that. It sounds like you have a structured communication process in your open access model, where if patients are coming in before they see the provider, you're actually trying to get some information about the patient and get that to the provider ahead of time, so they're fully equipped with what they need to know in terms of medical information that best help that patient. That might be somewhat difficult to describe and demonstrate, but it is a structured communication process, it sounds like, that you're doing proactively.
So finally, something that removed a little of my nausea.
Well, I'm so glad.
I think, you know, our standard work, and it's laid out for our MAs, I think will suffice, because that's a document that all the MAs know they have to follow, and the things that they're to gather before the provider goes to see the patient. So I think that will suffice.
Well, good.
I'll be quiet now and let other people ask questions, but I have another one when you're ready to wrap up. Thank you.
Okay.
Well, Tim, I'm so glad we were able to settle your stomach a little bit anyway.
You have no idea how tumultuous it was at the conclusion of the presentation.
Oh, okay. Tammy, you had a question. If you will, ask it to Candy. Tammy?
Did she put it, can you read the question? Maybe she had to get off.
Yes, I'll read it. I'll read it here. It's regarding Factor 6 in PCMH-1A. What if the practice is meeting their documentation goals? How do they show improvement, or do they need to?
That's a good question. And usually in PCMH standards, when they talk about identifying opportunities and taking actions in some of the other products, they usually will have an NA selection, and that would definitely suffice if you're meeting all your goals and benchmarks. They don't provide that with this first version of the standards, so basically you would have to write that out and show that you're monitoring and reporting, and then put there were no opportunities identified. And if that's the case, then I would select the yes response for that and provide that documentation.
Okay. Jill had a question. Jill, if you will. Jill Leonard. Okay, I'll ask the question for her. Are there any standardized tools to use for the health literacy factor in 3C10?
That's a good question, and I don't know off the top of my head if there are. Let me look really quickly in the standards and see if they provided any. I'll be happy to take that offline if I can't answer your question. Let's see, Factor 10. It doesn't give any examples in the standards. I know there are some health literacy tools, and I'll be happy to research that out, and we'll get a response out with some resources.
Okay, and Renice Anderson, she has a question as well. Renice, if you would go ahead, please.
Hi, can you hear me?
Yes.
Okay. I was wondering if you could explain what the record review workbook was.
Oh, explain what the record review workbook is? It is, yes, it's an Excel worksheet. NCQA provides that. And do you have access, have you purchased an ISS tool yet?
No.
Okay.
I don't believe so.
Okay. It's provided by
We're fairly new FQHC.
Okay. Well, it's provided by NCQA. It's an Excel worksheet, and basically you take a random sample of patients that would be identified in element A, which we talked about, which are those high-risk complex patients that you've identified, and NCQA provides you with a sampling methodology for how to sample. Now, I haven't seen the record review workbook for the 14 standards yet, but for the 11 standards, it was 48 patients that were randomly selected on various conditions that you've identified, and each of those factors within, for 14 is going to be 4B and C, I believe, are in that workbook. And then you go through and you're going to be looking in the medical record of the selected patients to see if it's been documented in that record that you meet that particular factor. The workbook auto-scores itself, so it'll tell you when you're finished with it whether or not you met the factor or not, and then you just upload that when you're ready to submit your application to NCQA, and that's all that you would show to document for B and C.
Okay, thank you.
You're welcome.
Are there any other questions? Are there any other questions? I can go through and unmute everyone if you would like, and that way we can address questions live as they come. If there's anyone.
If I could. Yeah, but I can't, and that's why it is, because everything else in my life.
Are there any questions?
Candy, this is Tim again, if I might. We had our CMO was in the room when you began the presentation. When does the 2014 standards take effect? Are we going to be able to submit this year under the 2011?
Yes, if you submit, we have to, I mean, I can't go back to the slide, but you have to have gotten your ISS tool purchased by June, the end of June this year. If you have purchased your ISS tool for whatever site you're going to be submitting under, then you have until March 31st of 2015 to do that.
Okay.
The key is, the key is, if you have not purchased your ISS tool, then, and you want to do the 2011 standards, then please purchase it. You don't have to submit. You just purchase the tool. It's $80, but you have to have it purchased and downloaded by the 30th of June this year.
Very good. And knowing this, though, helps us prepare those things that need 2 years worth of data and all, helps us to be prepared and to be running those reports.
Exactly.
So, thank you.
You're welcome.
Do we have any other questions? Any other questions at all? You can answer them by, okay, here, I've got a question here. Devon has a question. Let me unmute here. Go ahead, Devon. You're unmuted. Well, Devon's question is, do you have to purchase an additional ISS tool for a second location?
That is correct. For every location, you have to purchase its own ISS tool. So if you have 4 locations, you would need 4 ISS tools.
And Tammy also asked the question, is there a threshold for the structured data fields of occupation and the name, contact information of other health care providers involved in the patient's care?
For factor, let me pull that up again. For factor, the other providers, no, that is not a structured data field. I believe the occupation one is. But the structured data field, that can be in support text. It can be any place that you can put it. And basically they want to see, the process, how do you get it in there, the source of where it is, and then I believe it's 3 examples. So you would show 3 different examples of where that has where that's been documented in a patient record. For occupation, that's under 3A. Let me look really quickly. But I think occupation is actually a structured data field. 3A. Yes, it is a structured data field, so a report would be needed.
Okay. Any additional questions? You can either type it into the question or raise your hand on the dashboard. Well, at this point, it looks like there are no additional questions. We appreciate you participating in our webinar today. If any of you are unfamiliar with PolicyPLUS, our online compliance management application, we'd love to be able to show it to you. It's a modular application that manages your policies and procedures in the document management module. It manages your credentialing cycle as well as individual credentials for your providers and your credentialed employees in the credentialing module. And it tracks key performance indicators for the organization as well as for your providers, and has a work plan part in the quality module. We'd love to be able to show that to you if you felt that it would be a benefit. Having said that, we appreciate your attendance. We'll keep you posted on the next one as more and new information is available, not only in PCMH, but in the FQHC world in general. We'll try to keep you up to breast of what's going on and any changes that are happening. With that, thank you very much, and we appreciate